Chronic bundle branch block. Anatomy. The His bundle divides into the right and left bundle branches. The left bundle branch immediately divides into 2 or 3 fascicles. Consequently, at least 3 major fascicles are known in all people. Right bundle branch. Left anterior fascicle. Left posterior fascicle. In 65% of individuals, the left bundle branch divides into 3, not only 2 fascicles. Left anterior fascicle. Left median, also called septal fascicle. Left posterior fascicle. Further division. The right bundle branch and the fascicles of the left bundle branch divide into smaller and smaller branches, until they end in the very small fibers called the Purkinje fibers. The Purkinje fibers form networks on the endocardial surface of both ventricles, and penetrate only the inner third of the endocardium. An almost simultaneous propagation of the cardiac impulse occurs to the entire right and left ventricular endocardium, thanks to the very rapid conduction velocity of the Purkinje fibers, 4 meters per second. Conduction velocity is 2 meters per second in bundle branches and His bundle, 0.5 in atrial and ventricular muscle, and only 0.05 in the AV node. Since the atrioventricular node and His bundle are right-sided, the right bundle branch, RBB, courses directly down the right side of the septum, while the left bundle branch, LBB, needs to penetrate the membranous septum to reach the left ventricle. The RBB is a long thin branch which courses directly down the right side of the ventricular septum, and does not divide until it approaches the base of the right anterior papillary muscle, with ramifications going to the septal and free walls of the right ventricle. The LBB needs to penetrate the membranous ventricular septum to reach the left ventricle, then divide into its fascicles. Chronic right bundle branch block may occur at any level. The most common is proximal block, but block may also occur at the mid part, the moderator band level, or the distal part of the right bundle branch, or even at the ventricular muscle itself. Moreover, events in the His bundle can manifest with right or left bundle branch or fascicular block patterns, because certain fibers of the His bundle are organized longitudinally, and predestined to activate only a certain fascicle. Left bundle branch, LBB. The main LBB penetrates the membranous ventricular septum under the aortic ring, and then divides into its 2 or 3 fascicles. The left anterior fascicle, to the anterolateral wall. The left posterior fascicle, to the inferior wall and papillary muscles. The left septal fascicle, to the ventricular septum. Site of block, uncertain. The site of block producing the characteristic ECG patterns is not certain in all cases because 1. Fibers to the bundle branches and fascicles are already predestined within the His bundle, as just described. 2. Both His bundle and bundle branch or fascicular disease may coexist. 3. Bundle branch and fascicular ECG patterns may result from conduction delay, even in the range of 10 millisecond, without actual block. Prognosis. Unifascicular block in the absence of apparent structural heart disease is usually benign. Bifascicular block may progress to complete heart block. Symptomatic patients, especially with syncope, have a higher incidence of progression to complete heart block than the asymptomatic. Patients with left bundle branch block and cardiac disease have the highest incidence of sudden cardiac death, among those with intraventricular conduction disturbances. When cardiac disease is present, the coexistence of right bundle branch block suggests advanced disease. New-onset right bundle branch block does predict a higher rate of coronary artery disease, heart failure, and cardiovascular mortality. Most deaths among patients with cardiac disease and bundle branch blocks are caused by ventricular tachycardia or fibrillation, and are not prevented by pacemakers. Complete electrophysiological study, therefore, is necessary in patients with syncope and bundle branch blocks, because ventricular tachycardia can be found in 30 to 50%. Isolated left anterior fascicular block does not imply by itself a risk factor of cardiac morbidity or mortality. In a healthy population, it can be regarded as an incidental ECG finding. Left posterior fascicular block is a rare finding, and is almost invariably associated with right bundle branch block, and together can progress to complete heart block. In acute myocardial infarction, this is associated with a high mortality rate during the first weeks after infarction. General ECG features in bundle branch block. 1. Prolongation of the QRS duration, its degree depending on the severity of impairment. With complete block, the QRS duration is greater than 120 millisecond, while with incomplete block, it is 100 to 120 millisecond. 2. QRS vector is generally oriented in the direction of the myocardial region in which depolarization is delayed. 3. T-wave is opposite in polarity to the terminal QRS deflection. Right bundle branch block. The initial 30 millisecond depolarization forces of the QRS represent septal activation which remains normal, from left to right, because it depends on the left bundle branch. That is why Q waves of prior myocardial infarction remain unchanged. Depolarization mid-forces in the subsequent 50 millisecond represent left ventricular activation, from right to left and posteriorly. Depolarization late forces beyond 80 millisecond represent right ventricular activation which spreads slowly, by conduction through the working muscle fibers, left to right and anteriorly. Right ventricular repolarization abnormalities in the form of secondary discordant STT changes finally appear. ECG criteria to diagnose right bundle branch block, RBBB. 1. The heart rhythm must be supraventricular in origin. 2. QRS duration depends on the severity of conduction delay as described. 3. In lead V1, there should be a terminal tall R wave, which may show as small r, deep S, tall R prime. Small r, small s, tall R prime. Or small r, tall R prime. 4. In leads 1 and V6, there should be a slurred S wave. 5. Discordant T waves, known as appropriate T-wave discordance, that is, T-wave vector opposite in direction to the terminal part of QRS complex. Concordant T-waves, on the other hand, may suggest ischemia or myocardial infarction. 6. The QRS axis is unaffected by RBBB alone. Left axis deviation can indicate concurrent left anterior fascicular block, or other reason. Right axis deviation can indicate concurrent left posterior fascicular block, or other reason. The most characteristic features of RBBB are, terminal tall R wave in lead V1, slurred S wave in leads 1 and V6, and discordant T waves. Incomplete RBBB. An incomplete RBBB can result from lesser degrees of conduction delay. Incomplete RBBB patterns can be produced by various mechanisms. Block in the main right bundle branch, due to different degrees of conduction delays, or elongated stretched branch. Or block in the Purkinje system, due to right ventricular stretch or dilatation, surgical trauma, or congenital variations. Concealed RBBB. RBBB may be concealed in presence of 1. Greater degrees of conduction disturbances in the left bundle branch or its fascicles, or the left ventricular free wall. 2. In WPW syndrome, if there is pre-excitation of right ventricular regions, that would be activated late because of the RBBB. Left bundle branch block, LBBB. Unlike RBBB, the normal sequence of ventricular activation is altered dramatically in LBBB. Normally, the first part of left ventricular myocardium to be activated is the septum, via a small septal branch of the left bundle branch, with impulse spread in a left to right direction. In LBBB, activation originates from the right bundle branch in a right to left direction. Initial 30 to 50 millisecond depolarization forces of the QRS represent septal activation in a reversed direction and right ventricular activation. Vectors are oriented from right to left and usually anterior. Depolarization mid-forces at 30 to 50 millisecond into QRS represent left ventricular activation, which spreads slowly by conduction through the working muscle fibers, with vectors oriented right to left and posteriorly, because the ventricle is a leftward and posterior structure, resulting in a signal of large amplitude, due to the large left ventricular mass and lack of opposing right ventricular forces. Depolarization terminal forces represent activation of the anterolateral left ventricular wall, producing a small vector also directed right to left and posteriorly. Repolarization ST segment and T wave vectors are discordant to the terminal QRS deflection, like RBBB. ECG diagnostic criteria of complete LBBB. 1. The heart rhythm should be supraventricular in origin. 2. Prolongation of the QRS complexes depending on the degree of conduction delay. 3. In leads 1, AVL, and V6, loss of the normal small q, and initiation of a wide R wave usually with a notch on its top, with no S waves. In presence of septal myocardial infarction, there is pseudo-normalization of septal depolarization, that is, reappearance of Q in leads 1 and V6. 4. In V1, small r deep S, if enough anterior forces occur, or deep QS complex, if anterior forces are not enough. 5. Discordant T waves from the terminal QRS vector. 6. QRS axis of most uncomplicated complete LBBB is usually not located beyond -30, that is, within normal. Complete LBBB with left axis deviation more than -30 indicates a great degree of left ventricular His-Purkinje system and myocardial disease. The most characteristic ECG features in LBBB are loss of the normal small q, and initiation of a wide R wave usually with a notch on its top, with no S waves in leads 1, AVL and V6. In V1, small r deep S, if enough anterior forces occur, or deep QS complex, if anterior forces are not enough. Discordant T waves from the terminal QRS vector, that is, positive in V1, but inverted in V6. Incomplete LBBB. Incomplete LBBB can result from lesser degrees of conduction delay in the left bundle branch. Left ventricular activation begins abnormally on the right side of the septum, as in complete LBBB. But much of the subsequent activation occurs via the normal conduction system. Incomplete LBBB is characterized by QRS morphology reminiscent of complete LBBB. QRS duration, 100 to 120 millisecond. Diminutive or absent Q in leads 1 and V6, frequently replaced by a slurred initial upstroke, pseudo-delta wave. This pattern can be confused with WPW ECG pattern, although PR interval should be normal in cases of incomplete LBBB. Thank you.